Welcome to This Explainer. Today, we're going to build a rigorous foundation in intestinal motility, really to help you, the future doctor, navigate one of the most vital clinical decisions you'll ever make, knowing exactly when not to operate. It's incredibly easy to think of surgery as just a mechanical fix for a mechanical problem, right? But the human intestine is far from a simple plumbing system. It is a highly complex, fiercely autonomous organ. And when its intrinsic pacing fails, reaching for a scalpel can actually be the most dangerous thing you could possibly do. So here's our roadmap for this explainer. First, the physiology of intestinal motility. Second, acute adynamic states. Then, chronic dilatation disorders. And finally, the strict limitations of surgery. Let's dive right in. Starting with Section 1, Physiology of Intestinal Motility. It's all about respecting the gut's autonomy. Now, what's absolutely fascinating here is that the gut is completely autonomous. It's governed by the enteric nervous system, which literally acts as a powerful little brain. To really put that into perspective for a second, this intramural network contains 5 times the number of neurons as your entire spinal cord. Arranged in the myenteric and submucosal plexuses, this little brain means the intestine can initiate and sustain rhythmic peristalsis completely independently, with absolutely zero external input from the central nervous system. It's doing all the heavy lifting on its own. And working right alongside that little brain are the interstitial cells of Cajal. These are the critical pacemaker cells resident in the muscularis propria that electrically prime the smooth muscle to contract. You can think of them kind of like the sinus node of the heart, constantly generating the slow wave activity that keeps things moving smoothly. Now, while the autonomic and central nervous systems do provide higher-level environmental cues, like adjusting your motility when you're super stressed out or when you smell your favorite food, the fundamental rhythm is entirely local. It's driven by this beautiful, self-sustaining myogenic and neurogenic partnership. All right, moving on to Section 2, acute adynamic states, specifically ileus and Ogilvie syndrome. So the absolutely crucial point here is distinguishing between these two acute states because their clinical contexts are entirely different. Postoperative ileus, or POI, is an adynamic state primarily affecting the small bowel. And it's not just a paralyzed bowel, it's actually a complex two-phase response. First, you get an immediate stress response mediated by the HPA axis, and that's followed by a prolonged inflammatory phase where mast cells, macrophages, and neutrophils actively dysregulate the bowel's motility. In stark contrast, acute colonic pseudo-obstruction, which you probably know as Ogilvie syndrome, is a massive failure of the large bowel. This typically strikes patients who are severely frail, maybe battling advanced neurological diseases like Parkinson's, or recovering from major orthopedic trauma. It represents a profound, system-wide autonomic imbalance. And when you encounter Ogilvie syndrome, the sheer scale of it is genuinely terrifying. Radiologically, you'll see massive, widespread gaseous dilatation. And intraoperatively, the reality is even more stark. The bowel wall is stretched to its absolute physical limits. It completely lacks the muscular tone required to move any contents forward. It's a system completely overwhelmed. You've got to remember that this kind of stretching translates to a literal high-stakes clinical emergency. In Ogilvie syndrome, once that cacal diameter exceeds 12 centimeters, the mechanical tension on the bowel wall becomes critical. If your patient starts developing tenderness or peritonism, listen to me, that is a glaring red flag for impending ischemia or perforation. That's a complication that occurs in about 3 to 15% of cases, and it carries a brutal mortality rate that can reach up to 60%. Rapid decompression isn't just an option here, it is absolutely mandatory. Because emergency surgery in these frail patients carries such immense mortality, we rely on a very strict, stepwise algorithm to decompress the colon. Step 1 is always conservative. You correct electrolytes, treat any underlying infections, and immediately stop offending medications, especially opioids and anticholinergics. Step 2 is endoscopic decompression. If both of those fail, then we move to Step 3, pharmacological intervention using intravenous neostigmine. But caution is key here. This drug causes profound autonomic effects like severe bradycardia and bronchospasm. So strict cardiac monitoring and standby atropine are absolutely required. We save the knife, which is Step 4, exclusively for absolute failures or an impending rupture. Let's shift gears to Section 3, chronic dilatation disorders. Looking closely at intestinal pseudo-obstruction. Intestinal pseudo-obstruction, or IPO, is a really tricky clinical mimic. It presents with the exact same signs as a mechanical small bowel obstruction: severe pain, massive distension, vomiting. But here's the catch: there is no physical blockage. Instead, it's driven by primary rare myopathies in infants or secondary causes in adults like scleroderma, amyloidosis, or paraneoplastic syndromes. Essentially, it's a diffuse neuromuscular disease. And because of this, surgical resection is totally impotent. In fact, operating actively worsens the patient's prognosis by introducing adhesions, which just speeds them along a vicious spiral toward lifelong intestinal failure and parenteral nutrition. Because of its devastating nature, it is tragically often termed the motor neuron disease of the gut. Which brings us to our final section, Section 4, the strict limitations of surgery, focusing on constipation and irritable bowel syndrome. Much like dealing with the acute crisis of Ogilvy's, managing chronic constipation requires serious discipline and a rigorous, stepwise approach. We always start with lifestyle and dietary modifications. When those inevitably fail in severe cases, we move to oral laxatives. Step 3 involves specialized therapies like biofeedback or transanal irrigation. You absolutely must exhaust all of these options long before ever considering Step 4, which is surgery. A subtotal colectomy is an irreversible last resort, reserved only for highly selected patients, simply because it carries a massive risk of leaving the patient with ongoing, debilitating pain and bloating anyway. Please pay close attention to this next academic warning. Irritable bowel syndrome, or IBS, is a functional disorder. Let me be clear, there is no role for surgery here. Unnecessary surgery in IBS or functional constipation leads straight into a vicious spiral of visceral sensitization. By operating, you risk creating adhesions, you inadvertently validate an endless harmful search for some hidden organic disease, and you ultimately inflict profound harm on the patient, significantly worsening their long-term prognosis. So, by understanding those delicate pacemakers and the sheer, incredible autonomy of the gut's little brain, we arrive at a profound truth. As you step forward in your clinical journey, you have to ask yourself a hard question. When you're faced with a dysfunctional gut, are you truly fixing a mechanical problem, or are you just permanently damaging an autonomous nervous system? Sometimes your absolute greatest intervention is knowing exactly when to leave the scalpel on the table. Thanks so much for joining me on this explainer.